I'm a true believer of this, and I think all of you are, that we must serve as advocates for our children in Pakistan. With a large population and 48.8% of us, of the children of the population being under 20, we also have a highly inbred community with cousin marriages and same caste marriages. Children's Hospital and Institute of and University of Child Health it's a large tertiary care center, and I think it's the second largest on the globe, with patients from all over the country queuing up early in the morning. And basically, we are a victim of our own success and overloaded. Now, the major burden of disease in Pakistani children does stem from infection and malnutrition, but the next big and less understood and less highlighted is the huge burden of genetic diseases. Now, why do we need to talk about consanguinity and genetic diseases? Because 73% of Pakistanis will marry in families, and in certain areas of KPK, it can go up to beyond 80% in the rural areas. So after infectious disease and malnutrition, the biggest killer of children in Pakistan would be genetic diseases. Now, so almost 50% mortality in infancy is from genetic diseases, and that's a conservative estimate. But are we medically aware of that? It's very poorly taught at the undergrad and postgrad level. So consequently, poorly understood. Very few physicians are interested in diagnosing or managing. So millions of children with rare diseases are virtual health orphans in our country. Now, patients undergo a virtual health pilgrimage to seek diagnosis, seek treatment, and I call them health orphans. Now, the socioeconomic disparities are huge in Pakistan. We really don't have a lot of regional centers, and before 2013, before our center started, maybe you were seeing some patients in Ağakhán, and then there really was no rare disease center in Pakistan. Successive governments have failed to implement a rare disease policy, and we were the first public sector hospital to propose a research and genetics center. Now, how did a gastroenterologist like myself, because I'm a gastroenterologist, and why did I start out start getting interested in setting up a rare disease center? Is because children with various genetic and storage diseases are referred to the gastroenterologist or hematologist. Many had terminal counseling to take the baby home as there's no chance of survival. Parents would have lost more than one child, and some parents had lost all their children. And with huge number of patients coming to Children's Hospital, every specialty I was seeing in our hospital were having a major burden of genetic diseases. So look at this picture. Does it mean anything to you? Not really, till we put a name to the disease, because you need access to diagnosis before it opens up the gates for any treatment or any counseling. And so that was very, very important for us. And if you look at this family where all these three beautiful sisters, they have the same genetic disease. They are on treatment and doing well. They have Gaucher. But then there's pressure on the mother to have kids, and not only children, but also have boys. And many, they're not really counseled about disease, and they continue to have more sick babies. So my journey, or we could say our department's journey or Children's Hospital journey, began in 2006 when we had no access at that time to either diagnosis or treatment. Very costly to send samples abroad. We couldn't be sending thousands of samples across and charging everybody. If you have no diagnosis, you have no counseling or prenatal testing. It was very important that we opened a discourse on genetic diseases, on consanguinity, on the importance of understanding why genetic disease is so prevalent in Pakistan. And thankfully, this topic is not a taboo any longer. And well, it did need a multi-pronged approach, and it still does. And I would say anybody who thinks about establishing a rare disease center has to work on all these aspects. Number one, which we started off, was awareness and public education, and a massive level of public education. Then establish an access to diagnosis, which would open the gates to treatment, and then come to also the prevention of the prenatal. For this to happen, we did not at that time have resources or trained human resource even, or economic resource. Multiple collaborations and networking actually helped. We had the diseases, the world had the tech. And so we did have a breakthrough of actually collaborating with the German scientists, with Centrogene, with our census, also in the US with the Yale Genome Center. And that really opened the gates to diagnosis for us. So we started not only having these clinics in Lahore, but having them in all the major cities of Pakistan. Now and finally, in 2015, the Rare Disease Center, the University of Child Health materialized. Now the human resource of the Rare Disease Center basically is the team of gastroenterology and the fellows who are training there, and the endoscopy nurses who are giving therapies. And the endoscopy suite holds all the refrigerators for the treatment. And the Rare Disease Center, it is housed within the unit. These are children who are coming for their infusions. They're watching television while they get their enzymes. And so the genomic testing, this is one of our older papers that we published after testing more than 1,000 patients from various Pakistani families, which showed a very high diagnostic yield. And if you look at that, 61.3%, or even more, because some were almost 20% reported as VUS. So you could say almost 80% had a genetic diagnosis. So how is it possible to ignore the rare diseases or genetic diseases in Pakistan? It's also interesting, we recently published another paper looking at secondary findings in the Pakistani population. When we test them, we also take a consent for telling them or exposing them to the secondary findings, which to our surprise, in the overwhelming majority were related to cardiac disease in our country. Now, one of the biggest burden that we have seen that we have among the genetic or rare disease are the lysosomal storage disorders. And the biggest number is of Gaucher. We have a large number of the MPS and many other LSDs. You can see quite a large number of Niemann-Pick over there. And so these are older picks of patients, and that's the reason we started it. That they're coming to us late. They are coming. We have early and severe phenotype, and if you look at these, how can you save these kids? Many of them did not survive, and it was very important to diagnose them in time and have access to treatment. And this is from the Rare Disease Center. If you look at our data of LSDs, you can see that the large majority are the Gaucher. Now, seeing the large majority of LSDs from all over the country, first we established the database of our unit, and now we're part of the international registry. Today, 90% of children with a treatable LSD get treatment at the Rare Disease Center. Now, because of the Rare Disease Center, we are now able to know what is the genotype of our patients. So, and we can correlate it with the early onset disease in Gaucher. So the genotype, which is L444P in 78.3%. And this is the world's largest cohort of GD3, for which that is why we have now entered into the clinical trial for better therapy of GD3. And you can see that Gaucher has a huge impact at the Rare Disease Center with the enzyme replacement, which are on ICAPs. And we were also partners at the Rare Disease Center of the world's largest study of lyso-Gb1 as a predictive biomarker in treatment-naive patients with Gaucher. We were also the world's largest contributor on the multi-center, multi-site study of the multi-omic approach, looking at the biomarkers for metabolic diseases. The huge impact of the Rare Disease Center on the Niemann-Pick, because Niemann-Pick B patients are now on enzyme replacement. And I've recently received some patients from the south, from Karachi, we have put on enzyme replacement. MPS now, we were doing bone marrow transplant, and bone marrow transplant is now in our hospital. But the latest revolutionary thing which happened is one of our families who the child died after bone marrow transplant 1 or 2 years later. But in the next pregnancy, the prenatal testing done revealed that the fetus is affected. So the family opted to be part of the clinical trial of intrauterine enzyme therapy. The intrauterine therapy was given in University of San Francisco, California, at the Benioff Children's Hospital. The team remained in constant touch with us. Baby has come back to Pakistan. He was born well with a very low level of blood biomarker and is on regular ERT. And you can see from the baby's face that he does not have the prototypic features. Our other patient of Pompei's, CRIM-negative Pompei's in Canada, received intrauterine ERT, and the baby is now on replacement postnatally and is doing extremely well, unlike our other CRIM-negative who never made it despite ERT. Now, another big problem in Pakistan is the lack of universal newborn screening. And the last few slides I would like to share with you are on other rare disorders. So we do not have data in Pakistan about exact prevalence of these disorders, other inborn errors of metabolism. We do plan to start a massive project of newborn screening of over 0.5 million children over 3 years now, free of cost, and Children's Hospital will be the regional center. And I think Ağakhán is doing a similar one. So this is just to show you our data from the Rare Disease Center of the organic acidemias. A large number is also seen by the Metabolic Center at AKU under Dr. Bushra Afroz. So our most common organic acidemia would be the biotinidase deficiency, MMA, and propionic acidemia. Now, again, it's important to have access to diagnosis in time. These are disorders where you can save the child with a normal brain and he can have a normal life. And this is a family who lost 3 children before due to biotinidase. Again, the MMA, which is B12 responsive, extremely common in Pakistan, and huge and large numbers have been diagnosed at the Rare Disease Center. Now, among the various aminoacidopathies that I'm telling you that we have diagnosed, the very interesting ones are the tyrosinemia, the lysin-uric protein intolerance. In case of tyrosinemia, the importance of the Rare Disease Center can be highlighted by the fact that this is one of our previous patients in 2006, where we had no access, we suspected, but we had no access to genetic diagnosis nor to the medicine. But fast forward to 2022, in the Rare Disease Center, we have access to diagnosis for these patients of tyrosinemia and access to therapy. So access to diagnosis in diseases which are genetic or rare is extremely important. If you come to cholestatic disorders, we still teach in our FCPS that biliary atresia in Pakistan is the commonest cause of neonatal cholestasis. But from the Rare Disease Center, our data shows completely opposite. The biliary atresia was 15% of the patient, while genetic cholestasis were 40% of the patients. And it's important to see that among the frequency of inherited cholestatic disorders, our largest chunk was ABCB11. So FIC2, but we have all the other common and uncommon cholestatic genetic disorders. Because of the inbred community, you can see from the data that we have all the different varieties, and they are more common than biliary atresia. And these are the patients of progressive familial cholestasis, where it is the most common indication of early liver transplant in Pakistani children. Now, access to therapy through the Rare Disease Center, as I said, parents don't just need a diagnosis, they need treatment. And so getting these orphan drugs into the Rare Disease Center has been our biggest achievement. So you can see that the bile acid transport inhibitors, the IBAT inhibitors, We have patients on ICAP on that, the cholic acid for the inborn error of bile salt, and the nitisinone. And these families who, kids who are dying with this diagnosis of inborn error of bile salt, synthetic defects, and these you can see this little girl who was one of the only surviving children. It's very important to diagnose immunodeficiencies and congenital diarrheas. And we have a large cohort of the congenital diarrhea and enteropathy patients. And this is one of our patients with a tufting enteropathy. But if you look at the frequency of the gene identification with congenital diarrhea and enteropathies, it is 46%. That highlights to you the importance of diagnosing rare diseases in Pakistan. And if you look at the immunodeficiency disorders, our biggest chunk is severe combined immune deficiencies, but all kinds of immunoregulatory defects are there. With the bone marrow transplant center available in the university, it is giving a good service to these patients with immune deficiencies. And when diagnosis translates into life-saving treatment, this little baby with very early onset IBD was diagnosed with IL-10 deficiency and has undergone bone marrow transplant. So we can, running to the last bit, since I'm short of time. So it's so important to have access to diagnosis and prenatal and treatment under one roof. Many times we have a patient referred for, let's say, liver transplant, where the genetic testing confirms that patient actually needs a bone marrow transplant, not a liver transplant. So confirmed diagnosis is everything. And if it's treatable, it's a life-saving investment. If not treatable, then a diagnosis puts a stop to all the expensive, useless investigations, like lots of MRIs and CTs and EEGs, and becomes possible to offer genetic counseling. And with the massive genomic sequencing at the Rare Disease Center, we have been able to have a huge bioinformatic database and large number of papers published and new diseases discovered. A local expertise developed for having some start of the prevention as well as diagnosis work on the genetic front. But we have seen a lot of obstacles, and we have seen a lot of things which we think need to be improved, as we saw over the time, that pediatricians do not document the details of a sick child. They do not advise parents about testing despite 2-3 dead babies. I'm not talking about tertiary centers, but lots of doctors sitting, practicing, pediatricians everywhere. They're shy of the word genetics, and the medical curriculums have not evolved to match the scientific pace of advancements. And we do need to talk to our obstetric colleagues about improving our fetal-maternal medicine and our failure of successive governments to implement a rare disease policy. And prevention is important, and this is what we have been doing at the Rare Disease Center. This is prenatal diagnosis. I think we've done a lot, but there's still a lot of pain and a lot of unmet need. And we can see from the Rare Disease Center at the university, it reveals a huge burden of rare and genetic diseases in Pakistan due to consanguinity and same caste union. Families of children with rare diseases, they travel to the Rare Disease Center for access to diagnosis and treatment under one roof, but they travel long distances. We need to have more centers. We need to have a government policy for rare diseases. We need public education, awareness, and prevention is the key. We should invest in diagnosis rather than scans worth millions. Access to orphan drugs to the Rare Disease Center has had a dramatic impact on outcome. But at the same time, we need better access at all centers. We need to upgrade our medical curricula to match the pace of advancement in science. We must develop our local registries and database more and more to understand burden. We need training of genetic counselors and collaborative research with other centers, which is extremely important. And I would say nothing is possible without a good team. And I'm really indebted to my excellent team of gastroenterologists, hepatologists who have worked with me at the Rare Disease Center and are now doing a lot of work with genetic and metabolic disease. I'm very indebted to our American partners, our German partners, and all my team of nurses. And I think without the team, we could not have done anything. Thank you.